Great. Well, welcome. Great to set off this podcast where we're going to talk about the paper recently out in North American Spine Journal entitled Implant in Situ Assembly for all posterior lumbar vertebral column resection, a technical note. I'm Jonathan Grauer, editor-in-chief of North American Spine Society Journal. And could you introduce yourself?
And I am Roland Roelz. I'm senior physician at the Department of Neurosurgery at the University Medical Center Freiburg in Germany.
Fantastic. Well, welcome. And thank you very much for the paper that recently came out. And just to get things started, I'm wondering if you can just tell us a little about the paper and the technique that you describe.
So essentially, what we were looking for was a less invasive way to perform 360-degree column resections at the lumbar spine, especially in light of the fact that we are facing more people who might not do well with large interventions, especially the elderly population of patients. So we were kind of inspired by all posterior approaches that were developed at the thoracic spine and tried to transfer this to the lumbar spine to make these interventions, which are commonly performed in a dual approach, like an anterior or retroperitoneal approach, to transfer them as well to a posterior only approach.
Fantastic, great. And the images and the illustrations in the paper really look good showing that. One of the things I just noticed from a technical perspective is that you talked about taking down both pedicles, where a lot of these in the thoracic were kind of going down one side. I'm speculating that's so you can get out additional bone and clear the end plates, but you know, it's always that balance of stability and all. I wonder if you could talk a little about that portion of the technique.
Well, especially at the thoracic spine, I take down both pedicles if I do a 360-degree resection in order to get the spinal cord mobile, so I can push it over to the other side. And if there is no space because the pedicle is there, I feel that removing the pedicle creates that space that is necessary for a safe and gentle retraction of the spinal cord. And at the lumbar spine, because the discs are very large and they should be removed entirely to allow a large footprinted implant to go in. In my perspective, it's necessary to resect, at least in part, both pedicles in order to get a good dissection plane for the discs.
Fantastic. That makes sense. And then certainly one of the real novel things in my read of this is assembling it in situ. You know, I think about a case where I was doing a lower lumbar vertebrectomy, and you try to use traditional implants and using the expander, just watching the nerve roots stretch to the point where I had a lot of angst with that. So I completely, can see the advantages of assembling it in situ, but maybe you can tell us a little bit about kind of how that works.
Well, I mean, in situ assembly of the implant, of course, requires an implant that is capable of doing that, and that requires a clip-on design of the end plates. And almost all implants available out there in the market, they are not designed for with a clip-on design. So in situ assembly is not possible, not feasible with most implants. Because they are the end plates are attached with a screw usually that is in a 180-degree direction attached to the central element, to the distraction element. Now, we have an implant that we commonly use for column resections or anterior column reconstructions that has large footprinted end plates, and the central element clips on to these. And this allows in situ assembly. And like this, we can use the corridor between the nerve roots and the dural tube to insert like 32 millimeter end plates, place them against the adjacent vertebra, and then place the distraction element, clip it on, and perform the distraction. We are still not perfectly happy because as you said, stretching of the root and so on, it still happens to a degree that is at the borders of our comfort, at the limits of what we feel is good. But that is more of a technical thing. A slimmer implant would be nice, and especially the tool that places the implant. If that could be slimmer, and there are manufacturers out there who provide such tools, that would be a real advantage in the technique.
And I would think, I mean, at the depth that you're working and the visualization, how is the engagement? I mean, obviously, one of the concerns I would think would be is, are you adequately engaged with that end plate, with the core? And, you know, how have you felt that's worked out? Have you felt confident in that? Is it visualization, feel? How has that felt to you?
Now, you can actually, you can see it when you have 100% like a perfect attachment of the end plate. You can see it because it's a very simple mechanism of a couple of dents that go into, I don't know the English word. And when it's perfectly attached, you can see that. You just pull the drill tube a little bit aside and you can perfectly see it when it's properly attached.
Fantastic. Good. And so, I mean, I guess one of the questions as people read this and think, oh, well, wow, this is something I want to put in my armamentarium, is how generalizable is this to kind of implants in general, if it's specific to this one, kind of availability for you and for other countries? Maybe you can tell us a little bit about that.
Yeah, the implant is provided by a German manufacturer, Ulrich Medical. It's called the Obelisk, and this implant is available worldwide. I asked people at the company, and they told me it's available in 36 countries, including Japan, the US, and so forth. So it's widely available, and it's truly the only one I could find on the market that has a true clip-on design of these end plates that doesn't require an additional screw attachment, a screw securing of the end plate or so on, because and that, in my interpretation, nobody ever kind of had that in mind when designing those implants, that in situ assembly might be worthwhile.
Yeah, I feel like some of the other ones I've done without a screw, but like it's a back table impacting the end plate on, and certainly I'd be worried about doing that in situ.
Exactly, you can't. You need a force that comes from a direction where you can't come inside it. Yeah, that's true.
Fantastic. Maybe you could tell us a little about the cases you've used it for. I mean, I know that's kind of covered in the manuscript, but in terms of what you see as best applications for this.
So we did oncological cases and infectious cases, and also deformity cases stemming from an old osteoporotic fracture that was fusioned. And in my opinion, the all-posterior approach is always is ideal for diseases that affect both the posterior and the anterior elements. So I don't think there is much of an advantage if you have no affection of the posterior elements, where you could just do a lateral vertebral resection and insert an implant. That's not too much of a large surgery. That is something that most spine surgeons are familiar with. But if you have to do both an anterior and a posterior resection, might that be due to tumor? Might that be due to a compression that you don't feel comfortable to decompress from anteriorly? Then you simply save an additional approach for resection, because you can truly perform a 360-degree resection of the lamina, both pedicles, even the transverse processes, and the entire vertebra, of course. What I also feel is a true advantage is that you do the large bony resection you do that in a prone position. So whenever you need to correct deformity, like add lower doses, the positioning of the patient, will that do for yourself, or you don't have to do anything? It's more like the opposite. You have to somehow stop the other elements, the posterior elements from the adjacent vertebra to collapse. And you will get a very good correction of deformity when you do an all posterior resection.
Fantastic. Good. You know, as people kind of consider this, are there technical pearls? Having now done it a number of times, are there things that you would point out to people that you feel like either you've learned along the way or portions of the way you do it that you think would be worth sharing?
Yeah. Well, in general, I believe that the challenges of the procedure lie within the resection. So I think an all posterior 360-degree column resection of a lumbar vertebra is something challenging. And I feel the most challenging part is a perfect dissection of the lower disc, because this requires an approach that goes through the axilla of the lower nerve root. And you have to have perfect display of that. You have to dissect it perfectly. And you kind of use strength with very structures that must not be injured. So I think the surgical challenges must be kept in mind. You have to know what you're up to. You have to know that this is something that is surgically challenging, and you have to focus for a certain time. The assembly of the implant itself and placing the implant itself is simple if it's well prepared. If you have the end plates perfectly prepared, especially the anterior aspect of the anterior and lateral aspect, you really need to, in order to place a large end plate, you have to really meticulously prepare the end plate to place this the vertebral end plate in order to put the implant. And this is something that I feel is technically challenging. And also, I would say that given the implants that are, or the implant that is available at the moment, it is still quite large, and it requires a certain mobilization of the neural structures. And therefore, also the roots, at least the from the side where the axis is chosen, they must be properly displayed, especially the lower root must be perfectly displayed in order to have it mobile. Yeah.
Great. And are you using temporary rods as a routine, or not needed in general?
I think it's a very nice way to do that. I haven't needed it yet. I until now I have just placed I don't know the English word. I'm sorry. Something to hold the wound open, the distractor, or the
like a laminar spreader.
Laminar spreader. Yeah. Okay. I just put that in between the spinous processes to prevent too much of a collapse, and that was enough. But I think placing, especially when working at the thoracic spine, where you definitely must be careful with compression of the spinal cord, I think there placing a temporary rod is a very good technique.
Fantastic. Well, this sounds really exciting. Are there any other things you want to share with everyone?
Is there anything I want to share? I think it's a technique that must be carefully developed, because it's I mean, we approached your journal and presented the first 4 cases that we've done, and we have done 4 more cases so far. Some of them also, and that is what I think is also a good opportunity for in situ assembly of the implant at the lower thoracic spine, where you want to place an implant with a large footprint, and so also at the thoracic spine, I think it's a very valuable technique, especially in patients with poor bone quality. But I believe that it must be carefully developed. So indications must be right, and surgeons who want to try it should feel confident and should kind of have a careful approach to it.
Fantastic, great.
Careful attitude.
Thank you so much for sharing the manuscript, for sharing your thoughts on this. This is really helpful and looks very promising.
Thank you so much.